Good morning, everyone, and thank you so much for joining us today. Happy New Year and welcome back to our Women with Heart online as we restart the program here in 2021. So thank you very much for joining. Today's presentation will be called Heart Failure Diagnosis and Management Perspectives for Women. Our speaker today is Dr. Varinder Randhawa, who's a PhD MD and currently a postdoctoral fellow at the Cleveland Clinic.
Thank you very much, Dr. Cote and Dr. Kalela, for the opportunity to present today. Good morning, everyone. So today what we're going to be talking about is heart failure diagnosis and management with a particular focus on perspectives for women. We are going to begin first with the following agenda items, talking specifically about the definition of heart failure as a syndrome, why this is important, what are the statistics, a discussion around risk factors and stages of heart failure as a clinical spectrum, the two most common causes of heart failure, their signs and symptoms, the clinical exam that we undertake as healthcare providers, as well as the diagnostic tests and some of the key medical therapies that you may find yourself on as a person with heart failure. I have no known disclosures. So let's first talk about the definition of heart failure. As I mentioned earlier, heart failure really is not an isolated disease. It's in fact a syndrome that results from the heart's inability to pump enough blood through to the body as it normally would. And much like a traffic jam along a motorway where the exits are blocked, this can lead to a backup and congestion of fluid. Over time, this causes the heart to stiffen or stretch and leads to a number of other changes in the way the structure of the heart looks and functions. So why is this important? Well, we know that over 2.5 million women worldwide are actually affected by heart failure. And in fact, with an aging population, this incidence and prevalence of heart failure is projected to increase, especially in women as they age. Now, heart failure is a chronic disease syndrome that exists along a spectrum. You'll notice on the top right-hand corner is a graph. There's a lot of dips and valleys and peaks along the way. Some of these valleys account for when patients are admitted to hospital with decompensated episodes of heart failure. And with treatment, they move along to the peak of their condition. But we also know that over time, there's a chronic decline in the condition of the patient as the disease or cardiomyopathy progresses. Cardiomyopathy can be inherited or acquired, and we know that this is a particularly costly issue, not only to the healthcare system, but more importantly to our patients in a whole host of ways. The Canadian Women's Heart Health Alliance analyzed some data from 2016 and 2017, and in fact found that heart failure as a syndrome was the second leading cause for hospital readmissions and the third leading cause for cardiovascular death, in addition to causing this cardiomyopathy that leads to this trajectory or chronic decline. Heart failure results from a number of risk factors that affect the heart structure and its function. In women, this can include spontaneous dissection of the coronary artery, or as women age, can result from blockages in the artery of the heart. There may be heart rhythm or heart valve problems. There can be inherited congenital or genetic conditions that predispose to heart failure, and sometimes certain cardiac risk factors, for example, high blood pressure or hypertension or diabetes, particularly in pregnancy, along with other risk factors may increase the incidence of heart failure. And finally, other miscellaneous stress factors like emotional stress or drug toxins, for instance, certain chemotherapeutic agents, and patients who may have breast cancer, which is particularly prevalent in women, can result in heart failure conditions. But heart failure, as mentioned earlier, is not an isolated syndrome. It actually exists along a spectrum. And so while I may see patients most often for the very first time when they present with stage C or stage D heart failure, that is, there are already changes to the structure of the heart that result in a constellation of signs or symptoms that progress over time. What we want to do as healthcare providers is really try to prevent this progression from stage A through to stage D. Patients in stage A are those who are at risk of heart failure. So they may have conditions such as high blood pressure or diabetes. And we want to optimize those conditions to prevent the changes to the structure of the heart that can happen when those medical conditions are left uncontrolled. Sometimes the progression from stage A to stage D can happen very rapidly because of an acute insult or injury to the heart, or other times it can take some time to progress. But essentially, the pathophysiology is as such. There is an initial injury to the heart, for instance, a heart attack, that leads to a decrease in the ability of the heart to pump blood flow, that is, decreased cardiac output to the rest of the body. Because of the backup and congestion, that increases the pressures inside the heart and the volume of blood inside the heart, and that leads to remodeling of the heart, causing it to stretch. And this results because of decreased blood flow to the rest of the body that signals special receptors called baroreceptors that activate two different systems in the heart called RAS, or the sympathetic nervous system. The bottom line is that these two systems activate certain molecules that lead to the release of other stress hormones that in the acute phase cause retention of fluid and salt, cause the vessels of the body to constrict and increase heart rate. So while over the short term, this may be beneficial because it improves cardiac output, blood flow to the rest of the body, helps maintain blood pressure, increases heart rate to help improve the function of the heart. Over time, this can lead to deleterious effects that lead to fluid congestion, failure of the pump, and an increased expenditure of energy that's costly to the heart. Now, while there are many types of heart failure, what I wanted to focus on today are two most common types of left-sided heart failure. And that includes diastolic heart failure, where the pumping action of the heart is actually preserved. So this is heart failure with preserved ejection fraction, but thickening of the heart muscle leads to impaired relaxation because the heart muscle is too thick. This type of heart failure actually is quite common in older aged women. In contrast, the other most common cause of heart failure is called systolic heart failure, where the pumping action of the heart is actually reduced or impaired, and that is called heart failure with reduced ejection fraction. And this over time leads to thinning and weakening of the heart muscle such that it stretches the heart and dilates it. And this is more common in younger women. But what we know is that despite the many different causes of heart failure, the signs and symptoms that patients may experience are actually quite similar. And so because of the fluid backup patients may experience an intolerance to certain exercises that they would normally be able to do. Fluid buildup in the lungs can cause shortness of breath or dyspnea, which is worse when lying down, orthopnea, or even worse when lying down at night, paroxysmal nocturnal dyspnea. Patients may experience other symptoms like chest pain or palpitations, a sensation that their heart's pounding out of their chest. Fluid buildup in the belly can lead to a feeling of bloating and fullness, so that there is a loss of appetite. And fluid can also build up in other tissues within the body. And most often, you might see that the hands or legs and ankles and feet are swollen as a result. Now, the decreased cardiac output or ability of the heart to pump blood to other tissues may decrease blood flow to the extremities, so that hands and feet may actually feel cold or turn blue. And oftentimes, patients may complain that they have some degree of confusion or memory issues. But what is important to the healthcare provider is really, how are patients handling these symptoms, and how does it affect their quality of life and their activity levels? And so when we talk with our patients, we want to get a sense of what NYHA classification they are within, to determine their association between symptoms and activity level burden, such that patients who are NYHA class 1 really have minimal or no symptom or limitation to their ability to carry out their daily activities. By contrast, patients who have NYHA class 4 symptoms actually may have these symptoms even at rest, and that significantly impairs their ability to do their daily work. When patients come in to see the healthcare provider, we look for specific objective measures to see how much the heart is stressed and to give us a sense of the severity of the acute heart failure episode, or to see how much the disease or cardiomyopathy has actually progressed. And so we're interested to know if the blood pressure, heart rate, and respiratory rate are high or low, because that may be a consequence of stress on the heart or disease progression. Fluid buildup may lead to low oxygen saturations. Stress on the heart may lead to extra heart sounds when we listen to the heart. And listening for murmurs may tell us whether the valves are more leaky or more tight, and that can also contribute to heart failure. We also listen to the lungs to see if there are any fluid buildup by listening for crackles. And we look for other signs of congestion by looking at the swelling of the neck veins, the belly, and the legs. And as mentioned earlier, if the cardiomyopathy is quite severe or it's been uncontrolled despite medical therapy, we may see that the hands or feet may actually turn blue and feel cold. And because of the high use of energy over time, we may actually see chronic muscle wasting. There are special tests that patients may be administered to give us a sense of what causes the heart failure episode, and to also understand the severity, so that when we treat the patients, we know how best to treat them. Some of you may be well aware of a special blood test marker called an NT-proBNP or BNP. When these levels are particularly high, they tell us that the heart failure episode is quite severe. We may look for causes such as heart rhythm problems on an ECG. We may also look at the chest X-ray to see if the heart itself has enlarged in size, called cardiomegaly, or look for signs of fluid buildup with extra lines in the lungs, or effusions or fluid buildup in the crevices of the lungs called pleural effusions. We may do an echocardiogram, which is an ultrasound of the heart, to look at the heart structure, its function, and to see how well the valves are working and whether or not they're stenotic, tight, or leaky, regurgitant. We may do other imaging tests such as MRIs, PET studies, a coronary angiogram, and specific stress tests to tell us what is the underlying cause of a patient's cardiomyopathy or heart failure syndrome. And as an advanced heart failure physician, I'm also particularly interested in what the pressures are inside the heart and lungs by doing a right heart catheterization, or with my rehabilitation colleagues, doing a cardiopulmonary exercise test to determine how easily the heart tires or whether or not it's having trouble removing waste products. Because changes in some of these testing over time may give me a clue of whether these patients need additional therapies on top of medications, such as a mechanical heart pump called an LVAD or heart transplantation. But how do we routinely administer therapies to overcome the symptoms of an acute episode, but also more importantly, prevent disease progression? While diet and lifestyle and risk factor modification may seem quite simple, they're actually the mainstay of how we keep patients out of hospital and away from a heart failure exacerbation. And so this may include recommendations that you follow a low sodium diet and monitor your fluid intake. We know that less than 2 grams of salt is important in heart failure patients, and keeping your fluid intake to about 2 liters per day from all sources is also important. And in addition to that, you may have had a discussion with your healthcare provider of the importance of monitoring your weights every day, because an increase of 2 to 5 pounds on a daily basis that continues to progress is really an accumulation of fluid overload or congestion. It's important when you monitor your weight that you do so every day on the same scale and at the same time, generally in the morning, perhaps after your morning routine, but before you eat, and keep a daily log of that, so that if you notice that there is an increase of your weight every day, that's not reducing, you may need an adjustment of your medications, such as diuretics, to offload this fluid buildup, because fluid buildup can increase the stress on your heart, and that's something that we don't want to do. And then we also talk about cause-specific, guideline-directed medical therapies. So these are specific medications that have been studied in large population trials around the world that tell us that these medications in certain heart failure conditions have actually been beneficial. So let's focus on HFrEF, or heart failure with reduced ejection fraction, where the heart pump is actually weakened or ineffective. There are 4 foundational medical therapies that we know are beneficial in this setting. This includes beta blockers, which work to reduce the heart rate and therefore the stress on the heart. There are mineraloreceptor corticoid antagonists, which is a potassium-sparing diuretic that reduces stress hormone levels. There are oral vasodilators, such as an ACE inhibitor, an ARB, or more recently, ARNI or Entresto, which, in addition to reducing stress hormone levels, with the newest kid on the block called the SGLT2 inhibitors, reduces salt and water retention. The goal of all of these therapies really is threefold. 1, to make the patient feel better. 2, to help improve the patient live longer. And 3, to improve their quality of life by reducing the number of times they're admitted to hospital for these heart failure exacerbations. As we spoke on the previous slide, we may think about additional therapies under special considerations. So we may add additional diuretics if there's more fluid on board. There are certain specific causes, such as amyloid, which have special drugs that have been shown to be beneficial for those cardiomyopathies. And then in certain populations, such as African Americans, hydralazine and nitrate vasodilators have been shown to be more beneficial than other vasodilator medications. If the heart rate continues to be high despite beta blocker therapy, we may add ivabradine. And if the heart rhythm is abnormal, we may consider medications such as digoxin. These decrease the burden and improve the quality of life of patients. There are 2 of the 4 drugs that are actually beneficial to women who have heart failure with preserved ejection fraction, where the pump is not failing, but the heart is stiff. And that is the MRA and certain oral vasodilators. And then while all 4 of these medications should be considered in special conditions such as peripartum cardiomyopathy, which can affect women in pregnancy in their 3rd trimester or in the postpartum period after they've delivered the baby, we have to be mindful of which of these classes of medications are actually used for beta blockers, and we may refrain from certain oral vasodilators because of the effects on the growing fetus or the baby through transmission in breast milk, and use alternate therapies like hydralazine or nitrates, which do the same function during the period of delivery and breastfeeding. And as an advanced heart failure physician, I'm actually tasked to also think about additional device therapies when the ejection fraction is less than 35%, 50% being around normal. I may consider a defibrillator to prevent abnormal rhythms, or a CRT device, which actually helps the left and right side of the heart work together rather than asynchronously. And if patients are in stage D heart failure, I may think of a mechanical heart pump called an LVAD or heart transplantation. Now, there are newer medications that I'm not going to talk about today, but may be down the pipeline in 3 to 5 years because they're actively being studied in patients with heart failure who are being hospitalized with an acute and severe episode of heart failure. So it'll be interesting to see what the results of these medications are, especially in women and especially in patients with severe diseased heart failure, to try and improve their quality of life and their outcomes. So why do all of these medications actually work? Well, if we think back to the pathophysiology of heart failure, a lot of these drugs actually work along that same pathway that initially helps to improve cardiac output and blood pressure and ejection fraction, but over time, its chronic activation leads to deleterious effects. Well, these medications like beta blockers, sacubitril valsartan or Entresto, ACE inhibitors and ARBs and MRAs act at different levels of this pathway to prevent the bad effects of this pathway on the heart and to improve patient symptom, quality of life, and to prevent heart failure readmissions to the hospital. So what have we learned over the last 20 minutes or so? We've learned that heart failure is quite prevalent and that certain causes of heart failure are quite common in women. But despite the cause, whether it's HFpEF or HFrEF, the signs and symptoms that patients present with can be quite similar. And we've discussed certain tests that we use to help us understand the cause of heart failure, how severe the episode is, and how quickly the disease may be progressing so that we can prevent those bad effects. we've also finally discussed the heart failure therapies, which not only depend on the type of heart failure, but also what causes the heart failure and how severe a patient presents with an episode of heart failure. We've discussed that diet, lifestyle, and risk factor modification are the mainstay of therapy, in addition to treating the underlying cause and using certain medications to help us to not only improve patient symptom, patient survival, but also their quality of life by preventing them from having exacerbations that lead to heart failure, readmissions to hospital, and affect their ability to do their daily activities. So with that, I'd like to thank you for the opportunity to speak, and I hope that you've been able to learn something new or to remember something that you already know, and I'm happy to take any questions.
That's great. Thank you so much, Dr. Randhawa. That was awesome. As a reminder, to ask questions, you can use the Q&A function typically found at the bottom of your screen. It could be at the top as well, depending on what type of device you're using. So please feel free to type in your questions and Dr. Randhawa would be happy to answer them. I'll start and just kind of ask you if you can just touch on, and I think you did sort of bring this up a bit, but just a little more, just about physical activity and sort of cardiac rehab, exercise, this type of thing, and people who might be on fluid restrictions and what kind of precautions we need to take when doing exercise if you're on fluid restrictions.
Thank you for that question, Dr. Cote. That's actually very relevant for anybody that attends heart failure rehabilitation classes. We know that studies have actually shown that rehabilitation and exercise is important for heart failure patients. It helps them provide them with conditioning to improve their exercise tolerance. What's important, and where my cardiac rehab colleagues come into play, is that they can provide specific exercise prescriptions that minimize the demand on the heart. So while it's important to exercise, it's also important to know how to work and exercise in a manner that doesn't stress the heart. When we talk about diet and lifestyle changes, for instance, taking in too much salt and taking in too much fluid can actually over time cause stress to the heart. So while it's important to be hydrated during exercise, you do want to be careful not to drink excessively so that the heart does become stressed. So while it's important to be hydrated before undertaking an exercise class and to make sure that your electrolytes are actually repleted, and that's important, you don't want to excessively drink on those days beyond 2 liters a day. And that includes all sources of fluid, because again, these things can stress the heart.
Yes, great. And is it okay for patients to be doing both aerobic and resistance exercises?
That's a very good question, Dr. Cote. And while the short answer is yes, it is beneficial to do both aerobic and resistance exercises, again, depending on the patient. There might be patient-specific prescriptions as to what extent of aerobic or resistance exercises that they should undertake because of specific considerations around the stress to the heart. So, you know, some patients may over time actually find that with routine exercise and with routine resistance exercise that their conditioning improves. That trajectory actually takes a little bit of time, and it requires working with the cardiac rehabilitation specialists to build on that prescription and to condition the heart to those levels. And you may find that on some days, it's a little bit easier to do certain aerobic exercises and certain resistance exercises. What is, however, important is not to stress the heart too much. And that's where the exercise prescription or program becomes particularly important, so that, we can see how certain exercises are affecting the blood pressure and heart rate, because while it's okay to have a normal response of an elevation in blood pressure and heart rate in response to exercise, if these are excessively high in heart failure patients with pretty advanced heart failure disease, that may contribute to some stress on the heart. So it's really finding that fine balance.
That's great. We really appreciate you joining us today for this presentation, and hopefully you'll be back for another presentation at some point. Thank you very much for joining, and we will let you know when the next session is as soon as we know. So thank you and have a wonderful day.